brings me to my guest today, Dr. Nancy Moureau. We here at Infection Control today are lucky because Dr. Moureau is on our editorial advisory board. Dr. Moureau is an internationally known healthcare expert. She's an expert about a lot of things in healthcare, but primarily, I guess you'd have to say, peripherally inserted central catheter lines or PICC lines, in terms of long-term care facilities, nursing homes.
Yeah.
Are they properly staffed with vascular access teams or vascular access specialists these days, or any days?
So in my role as a clinician, as well as an educator and consultant, I've worked in a variety of capacities, from contracted work with long-term care and home care, to hospital and vascular access teams and PICC teams. And currently I'm working in home infusion that provides care to not only home, but other areas. And so, within our long-term care facilities, there are many needs. Patients are relegated to these areas, and they don't necessarily have the high-level resources that our acute care hospitals have. No, they don't have vascular access specialists. However, many of these long-term care facilities do contract with services in order to provide PICC insertions, midline insertions, even long peripheral catheter ultrasound guided insertions. And so by this mechanism, they can again partner with the specialist in order to provide the service without having to pay for a full employee and maintain that employee and the level of training that is necessary to keep them up to date and safe and competent with their insertion practices. And in fact, that's challenging for hospitals as well. I mean, we're talking about a vascular access specialist who has years of experience, has had to incorporate maximum sterile barrier procedures, modified Seldinger procedures, ultrasound guided procedures, and all of these don't come easy. They require supervised insertions. They require insertion experience and numbers in order to achieve a certain level of proficiency and competency. And we know from Joint Commission that they need to have supervised insertions on an annual or biannual basis in order to just validate that competency. We can also see competency validated by the outcomes, by the level of infection with their patients, with other complications that may be present. And so making sure that these specialists are functioning at a high level is very important and must be monitored. I do see this level of competency assessment in some of these contracted services that provide insertions within long-term care. And so it's achievable not only in acute care, but also in long-term care.
So when you say contracted services, you're talking about a third-party vendor. Is that fair to say?
Yes,
So
it is.
and it seems, I think you already answered this question, but does that raise some concerns about quality in your mind? You said they have to be monitored pretty closely.
Well, I think there's a degree of responsibility, professional responsibility that these contracted services require. The long-term care facilities are unlikely to monitor them. They're doing everything they can in order to provide care for the patients. But I know, for example, services out of Tennessee and out of Texas have very high functioning contracted services by owners that I know personally that run very tight ship. They hire people with experience. They provide additional experience for them, and they keep track of their outcomes. They do data collection and analysis. They monitor the processes in order to make improvements. I don't see that in all contracted services. Certainly there's variation from company to company. But yes, these outsourced services can function very well or not quite as high level as some.
Right. I'm paraphrasing what you just said. I imagine that you would prefer that the vascular access specialists or vascular access teams are associated with a hospital like Johns Hopkins, Cleveland Clinic, Mayo Clinic, um, which leads me to ask you, who do you think does this best? I mean, I don't know if you can name a name, but is there somebody that really knows, in your mind, vascular access, how it functions, where it fits in, and what resources should be allocated to it?
So there are publications that have addressed that issue of, what is the optimal process or methods that we should be using for vascular access? Not necessarily in terms of a company or even of a hospital. There are a lot of hospitals that do it very well. Um, Vanderbilt has an excellent program. The hospital that I mentioned in Hartford, Connecticut, uh, does a fantastic job. The hospital that I worked at, that is Prisma out of Greenville, South Carolina, excellent job with their vascular access team. But it's more than just one location. And it's hard for even one location to do it perfectly. So what we did was put together specialists, experts from all over the world to contribute to a book called Vessel Health and Preservation that is a free book. It's available open access through Springer. You can simply do a search for vessel health and preservation and find the PDF file of that entire book. There were more than 13 authors that contributed to this process of vessel health and preservation that shows best practice for a quadrant or a cycle that is used for vascular access from selection through insertion, management, and evaluation. This cycle of care can be implemented at any facility, whether acute care or outpatient. And the information that's included in this very comprehensive and lengthy book provides the structure and the information that they need in order to apply these guidelines, recommendations, and even best practices.
Dr. Moreau, is there something that I neglected to ask that you think might be pertinent for infection preventionists or members of vascular access teams or vascular access specialists to know in terms of COVID-19 and going about their business in the midst of COVID-19?
One of the things that we've seen with COVID-19, especially as it applies to vascular access teams, is the expanded scope of practice. And not necessarily that this was a desirable effect, but that these vascular access specialists, because of their ultrasound training, because of their ability to perform these procedures, have had to step up and move from peripheral insertions through into central insertions. So not only are they doing long peripheral catheters with ultrasound, midline catheters, and PICC lines, but they've also moved into axillary, subclavian, internal jugular, and femoral catheter insertions, preferably mid-thigh femoral. And so the expansion of these options that are available to the patient through this vascular access team have definitely helped the patient to move faster into a level of treatment that was necessary in order to help them to save their lives. Um, we see many physicians who have stepped up to the plate to try and help to bridge that gap of the need for vascular access insertions and central line insertions, most notably surgeons and others who found themselves available with the uh, lowered levels of elective surgeries and other things. But many of those surgeons had no experience with ultrasound. Um, some did, some didn't. And so they were doing central line insertions with what we call the landmark technique that we know is not as safe and has a higher incidence of complications um, because of inability to see. It's a blind insertion. Dr. Jack Ladon has spoken widely on the concerns associated with blind insertions. Um, as an expert and specialist with central venous catheters, he recognized these problems. And so working together with the vascular access teams, the surgeons could then help to learn some of these newer procedures work together in order to ensure safety. And so these expanded levels of practice, scope of practice for nurses that are primarily the people that populate these vascular access teams, or even a multidisciplinary team like those we see in Arizona and others that have respiratory therapists, that have physicians. Scottsdale, Arizona, the Mayo Clinic, they have a multidisciplinary vascular access team that includes all levels of clinicians. And so those types of teams I see are the most highest level functioning, work together, help to encourage and facilitate the development of the skills that are necessary in order to provide the services to these COVID-19 patients.
And it doesn't hurt that specialists in any field have an idea, or at least more of an idea of what specialists in other fields are up to or how they have to approach their job, I suppose.
Yes, working together, the collaboration, we know from the evidence, makes for much safer practice.
Dr. Nancy Moureau, thank you so much for being with us here today at Infection Control Today. And thank you also for being on our editorial advisory board. As always, a fascinating discussion with you.
My pleasure. Thank you very much.